All right, I'd like to thank everyone for not only joining us, but staying with us for what's been a very lively, timely, and important set of discussions around advancing hepatitis C elimination. So we talked about the challenges. We've talked about the opportunity with the Biden administration plan. We've talked about the pathways and examples of success and how they might be scaled and made more sustainable and more efficient as well, particularly in the last session from the standpoint of states and Medicaid programs. Remember, it covers a large number of people and could potentially cover more who are at highest risk of hepatitis C complications. And you heard from the last panel about the opportunities, thanks to some leading models from states, to go along with the leading models of care redesign, drug purchasing, and diagnostic procurement. That could be facilitated through state plan amendments, so-called SPAs, or the more substantial so-called Section 1115 waivers. There's a list, and we cover many of them in the report that was released today, that perhaps with a bit more momentum for the states, as you heard from the last panel, to collaborate, public health, healthcare, maybe with some limited initial upfront funding, could advance those efforts. So just to emphasize the importance of state healthcare programs, particularly Medicaid, and behind that, of course, is CMS. And we're going to focus in this session on federal programs. And we will have some discussion about the very important public health programs that are integral to the elimination plan. And to access to care for people who are uninsured and underinsured. But we also wanted to talk some about the Medicare program as well. And here on this slide are a list of Medicare Advantage supports, very much kind of the Medicare analog to the Medicaid and other CMS program supports that we talked about in the last session that could potentially help with advancing hepatitis C elimination. This includes steps to encourage DAA usage. We've already talked with Francis about the potential for an updated national coverage decision that would encourage broader access to the new one-step point of care tests, as well as reflex or other tests. We've talked about the clarifications and expansions of care management supports that are happening in many of these coordinated care programs and the SPAs and advanced primary care programs like implemented in Washington, New York, and elsewhere. There are Medicare versions of those programs for additional, over the last few years, payments in traditional Medicare and alternative payment models in traditional Medicare and other supports in Medicare Advantage to support more advanced coordinated primary care programs. And similarly, while the bulk purchasing or population-based purchasing arrangements are not common in Medicare Part D or Medicare Advantage plans, the same kinds of steps that we've talked about before, potential CMS guidance, performance incentives related to diagnosing and treating hepatitis C patients could provide incentives for adopting those kinds of models in Medicare as well. So aligned with the overall goals that we've talked about before and some important foundations to build on. So and would also add that Medicare and CMS standards are very important for how electronic health data is stored and shared. National electronic standards built into electronic record requirements for interoperability are the main mechanism used by healthcare organizations to support efficient and non-burdensome and secure data exchange. So very important roles in addressing many of the issues that we've talked about today. This slide has a bit more detail on the issues related to faster and better integrated diagnostic testing. We've talked about many of these topics already. In terms of hepatitis C disease detection and monitoring, this is an area where federal supports, including through Medicare, have been relevant so far. In terms of disease detection and monitoring, we've already talked about the CDC role in providing technical assistance to state health departments for data acquisition, case investigation, and so on. CDC also supports the development of local public health infrastructure. Resources are limited, but the CDC standards for this, these supports to state and local public health data monitoring are increasingly including some incentives and supports for moving towards national standard approaches that can be interoperable with healthcare data. And in addition, the HRSA has supported new uniform data standards for hepatitis C screening and treatment, which could provide a basis for standard electronic approaches for safety net clinics that are diagnosing and treating many patients with hepatitis C. Those standards in turn can be aligned with further CMS steps towards data interoperability through the Medicare program and the supports that CMS provides for safety net and other primary care and community providers. We also discuss in the report opportunities to align healthcare and public health funding and grants. So as the report describes, there are a number of programs across many federal public health agencies that aim to support hepatitis C screening, treatment, and associated services. Some of the best evidence we have on programs that work has come from some of those grant programs. A challenge with the grant programs is that if the grants are temporary, the programs tend to be as well. So one approach that we describe in the paper builds on steps that are being taken now to work across public health agencies and CMS to try to align the goals and the implementation supports for hepatitis C screening, treatment, and data sharing to advance elimination. So we're going to talk about some of these issues with the panel. Again, the paper describes it in more detail, and I hope to get into it with our participants today. Very pleased to welcome, and Lee, you should come on up now too, Dr. Lee Fleischer, former Chief Medical Officer, Director of the Center for Clinical Standards and Quality at the Centers for Medicare and Medicaid Services, which is kind of the epicenter, as we'll hopefully talk about a little bit, for how CMS promotes quality measurement, data sharing, and other activities that are very important for addressing population health issues. Nathan Furukawa is Senior Advisor for Hepatitis C Elimination in the Division of Viral Hepatitis at the Centers for Disease Control and Prevention. Joining us virtually, Dr. Christian Reimers is Associate Medical Director for Research and Special Populations and Director of Graduate Medical Education at the Family Health Centers of San Diego, which is a safety net, community health center network, very important for a whole range of important primary care, public health supports for vulnerable populations in that area. And finally, very glad to have with us Kristen Roja, the Public Health Advisor for HIV and the Center for Substance Abuse Treatment at the Substance Abuse and Mental Health Services Administration. So a range of federal perspectives with us on this panel. And I'd like to start out just by asking each of our panelists to give us some opening comments on the topics that we've been discussing today. And Lee, just going alphabetically, you come first, not to put you on the spot, but as I just described, there are a number of CMS steps on the Medicaid side as well as on the Medicare side. Maybe you can talk about, as described in the paper, steps that CMS is taking towards standard performance measures related to hepatitis C screening and effective treatment, steps to advance primary care more generally, steps to advance interoperability. Gosh, there's a lot of things that are going on at CMS that seem relevant to these topics today.
Thanks so much, and it's a privilege to be here. And of course, this reflects my experience from prior to July 31st of this year. But prior to my leaving, and I know they're still committed in the area that we talked a lot about, and I want to thank Francis for his leadership with Rachel, is this idea of currently there is a quality measure. It's do you screen for Hep C, but there's no effector arm. And that was really nicely brought to our attention, and I know that CMS is working on it. It's not on this year's what's called MUC list, or measures under consideration. But I think it's really important to recognize that we really need to close the loop. And given, Mark, a lot of what you talked about point of care testing and who is doing this, they may not be the people who are actually ordering the drug. So it probably is something, from my perspective, that has to be either treatment by the hepatologist or the GI physician, or referral to the appropriate physician to have what has to be an informed discussion about the drug. And what CMS is focused a lot on under Michelle Schreiber's leadership in the quality space is that interoperability and getting to a US CDI plus, which I know Duke-Margolis is very involved with, getting to that US CDI plus that's both healthcare and public health, not having them be two separate streams of sort of anchors of the definition, so that they really can be done using sort of modern techniques like FHIR to bring that in. The national coverage decision, I know that was a high priority. I heard from the NIH and from Rachel frequently about the importance of doing that. I know the issue is CAG is a mighty 37.
And for
people
those who
strong.
don't know, the inside CMS, CAG
Is the coverage and analysis group. So the group making all of the national coverage decisions, as well as overseeing how the local coverage decisions sort of work, but not doing the local coverage decisions, is 37 to 40 people, depending on the
And
day
when
of
you
the
say
week.
all national coverage decisions, that's not just things like hepatitis C screening, it's all the medical technologies, all the procedures, the whole spectrum.
And all the policies. So, I think it's important, and we've talked about the importance of getting enough resources. What'll be really interesting, because those point of care tests really weren't there in all the locations. And I think as part of any national coverage decision, for those who looked at the colorectal cancer screening national coverage decision, they actually didn't approve a test, but they approved a sensitivity and specificity for a test. So I think, really deferring to the FDA in what would be sort of how good a point of care test needs to be, and then it's automatically covered under sort of this U.S. Preventative Task Force. And I think that approach will be important. So with the right resources, I think a lot can be done. And I know there's a desire, at least from my old group, to align with this very important public health initiative.
Well, a lot to come back to there, but for now, let's go to the rest of our panelists and get some other very important federal perspectives. Nathan, I turn to you. Lots going on at CDC around advancing prevention, coordinating with healthcare. Your current director is an old colleague from North Carolina.
Yeah, thank you, Mark, for the chance to talk at this forum about all the things CDC has been able to do and is preparing to do in anticipation of this potentially really momentous initiative. So I'll leave you with kind of 3 points as I've been thinking through them. The first is that, CDC, John Ward was here under John Ward's leadership, and now Carolyn Wester. We've really been leading these core public health functions that are really essential to reaching viral hepatitis elimination. So that's providing leadership and vaccination recognition, providing leadership in science and public health practice on a number of different fronts, including developing testing and vaccination recommendations, conducting surveillance, doing outbreak response, and then monitoring progress towards elimination. That's establishing and describing these national trends in prevention, testing, and treatment, and then figuring out how we can support the implementation of these to reach the most disproportionately affected populations. And we're also working to raise awareness of viral hepatitis, improve provider training, and working through our partners in government, healthcare, and community to build and enhance capacity for Hep C elimination. And this is all happening at a pretty modest budget of about $43 million in annual viral hepatitis appropriations, and that's covering HEPs A, B, C, D, and E. My second point that I want to make is that despite this, we've been really anticipating this potential initiative and have worked hard to lay the groundwork for viral hepatitis elimination and Hep C elimination in particular. And some of the things I wanted to highlight of work we've done in the recent years include coming out with guidelines recommending universal Hep C screening among all people and during each pregnancy. We've also just recently rolled out recommendations for perinatal hepatitis screening. We've expanded surveillance from just initially 14 jurisdictions to now 59 to really try and get at a national picture of viral hepatitis around the country. We've worked to shape the development of the strategic planning and the targets for 2030 Hep C elimination. And then we've been working to really quantify these gaps and barriers and disparities along that care cascade. A recent MMWR on the viral clearance cascade showed, gosh, we have data suggest only about 1 in every 3 individuals has evidence of viral clearance, means we have so much further to go. We've also been working on developing an online hepatitis C curriculum that has trained thousands of providers. We've worked with jurisdictions to help them build their viral hepatitis elimination plans, again, preparing for that potential really game-changing initiative. And then we've also built programs in place in order to try and reach the people who would be the implementers, get money from the feds out into states and the community for them to be able to actually scale the prevention, diagnosis, and treatment services that are needed. All that to say is we've got some foundations in place, but by no means are current levels of funding sufficient. We ask our jurisdictions, can you make progress with the amount of funding you're given? And only 3% said that they were able to make notable progress towards elimination. So there's a huge gap, but with the right size funding, CDC is really ready to work to achieve hepatitis C elimination and do our part. Thanks in part to the real great leadership from Rachel, Francis, Risha, and Josh in the room, we've really thought hard about what CDC is well poised to do in the setting of a national elimination initiative. And I think we really lean into our strengths. So the kind of things I think we would be really great at is a national awareness campaign that both brings attention to the availability of hepatitis C treatment, but then also takes a tailored approach to reach those populations that are difficult to reach and help build demand for testing and treatment. I think we're also really well positioned to support building up a network of technical assistance and provider training. I think we've heard a lot over and over in this discussion about we've got to bring care to where people are, to where people with hepatitis C have trusted providers. And so that's getting out to community health centers, correctional facilities, substance use disorder treatment facilities, and SSPs. And so we want to create like a one-stop shop hub for people to be able to ask, how do I get the support needed to implement these programs, and then figure out ways to make them fiscally sustainable. We're doing a lot on the surveillance and data front, but we really would love to take this data and make it available at a more granular level to our partners at more local and community levels for them to help guide what are the optimal intervention strategies that exist, and then enhance our ability to really quickly detect new clusters of hepatitis C and intervene rapidly to interrupt transmission. And lastly, I think we, through our partnerships, would love to get out money to the implementers, the Colleens, the Judys out there who have been thinking about this for a long time and know exactly what they need to do to get the job done. So we're absolutely thrilled that we can be supportive of this national Hep C elimination effort, and really appreciate all the work that has been done and can be done.
Nate, thanks so much. You covered a lot of ground there. Again, lots to follow up on. Christian, I'll go to you next.
Thank you, Mark. It's great to be with you, and have to agree with all the speakers I've heard so far. Wish I was with you there in DC, but it is 75 degrees outside in San Diego. So
Yeah,
I think
don't rub it in.
I'm Christian Ramers. I'm an infectious disease and addiction medicine physician here, and I work in an FQHC. And while I don't work for the federal government, I think I have a good idea of what it looks like from the perspective of an urban FQHC. We are a teaching health center, so we have residents coming through our clinic learning how to practice urban family medicine, and also have 23 clinics, mostly serving poor and homeless and undocumented folks here in San Diego. I also do a little international work, and in the area of hepatitis C elimination, it's been very interesting to see programs in countries such as Egypt and Georgia and Rwanda have such an easier time at this than we have. And it reminds me of the work that's been done in HIV, where you have massive PEPFAR programs that come back to meetings like CROI or the International AIDS Society meetings and teach us the right way to do things, because we're busy kind of falling all over ourselves with the complexity of our own healthcare system. And what you see in really successful programs is simplicity, decentralization of care to the primary care level. You see task shifting from specialists out to primary care, nurse practitioners, physicians assistants, and you see integration into already successful programs. These are things that you hear Philippa Easterbrook from the WHO say all the time. And it's what happened in Egypt, a village-to-village approach, or Rwanda, a village-to-village testing approach, and having simple policies that reach those that are at the lowest levels. We also, the work that I've done with the Clinton Health Access Initiative is drive healthy market competition to get DAAs down to about $60 per cure, which is what they are in countries like Egypt and Rwanda. I'm not going to pretend that that's going to magically happen in the US, but at least we can get, with bulk buying, better prices. There's a reason why I think FQHCs are really the ideal partner, and I'm glad to hear Dr. Collins mention it in his New York Times editorial as well as in the plan. We are the ideal partner at the ground level, serving the underserved. 30 million patients in the United States, most of whom are either at or below federal poverty level, 65% of whom are minorities, 40% of whom are in rural areas, actually. And we have a network of 14,000 FQHCs around the country that are really ready and willing and able to answer this call. FQHCs are expertly tuned to respond to incentives. We have meetings where we go over UDS measures and HEDIS measures and literally twist and contort ourselves and our clinics and our processes to answer those measures. And right now, those are things like colorectal cancer screening or chlamydia screening or breast cancer screening or diabetes control or blood pressure control. And all it would take is really to put hepatitis B and C at the front of those measures for us to snap into place and really do the work that we need to do. We've also shown, I think, a nimble posture in that we can respond to pandemics. We've vaccinated people against COVID and influenza for the last couple of years, and really have that ability to get out of the four walls of the clinic, get out in mobile units, and even now these days do street medicine, treating people who are homeless, who are really, as one of the earlier speakers said, never going to make it into clinic to see a hepatologist. So from the FQHC, as I mentioned, we have the workforce. We have, I think, close to 300,000 healthcare providers ready to go. Primary care is not easy, and hepatitis C treatment actually is easy. So with the right amount of support, I've worked a little bit with Project ECHO. Only 1 out of every 10 or 1 out of every 20 cases is going to be complicated enough to need a specialist. And for the most part, primary care physicians, like those in the room with me right here behind me, we have 11 or 12 that are now treating hepatitis C actively, and their cure rates are just as high as the specialists, as we've published in 2020. So I have a couple of just ideas that I think are simple. They're right in front of us in terms of what other countries have done to make this easier than it seems to be. But put incentives in front of FQHCs, and we will respond to them very, very quickly. We also are constantly looking for grants and requests for proposals to do innovative things kind of outside the box. We have federal partners. I'm glad that Kristen is here to talk about the SAMHSA perspective because, for example, I saw 3 patients this morning with opioid use disorder who are getting methadone, and I really don't have any contact with the methadone clinic just because of the way our federal systems are set up. We could very easily be very close partners in terms of the hepatitis C treatment at methadone clinics where we know that there's positivity rates that approach 30 or 40% for hepatitis C. So many things that we could do to kind of get there, but it's very exciting to see all of the ideas finally coming together. It looks like maybe a bipartisan effort. I was doing a little reading on Bill Cassidy, and he actually is a physician who worked in a federally qualified health center and did a whole bunch of hepatitis B vaccinations when he was younger. So it looks like we have the right people involved. And I'll stop there, Mark. Happy to take questions later.
Great. Thanks very much, Christian. Lots to come back to there as well. Kristen,
Thank you very much. And my name is Kristen Roja, and I'm a public health advisor with SAMHSA, where I serve as SAMHSA's infectious disease policy advisor. And to start the conversation, SAMHSA, I want to share quickly SAMHSA's updated mission, which is to lead public health and service delivery efforts that promote mental health and prevent substance misuse, and provide treatments and service supports to foster recovery while ensuring equitable access and better outcome. SAMHSA envisions that people with, affected by, or at risk for mental health and substance use conditions receive care and thrive and achieve well-being. SAMHSA recently, in August of 2023, released our new strategic plan, which was released, covers 2023 to 2026. This new strategic plan presents a new person-centered mission and vision, highlighting key guiding principles and presenting new priorities, goals, and objectives. And to achieve its mission, SAMHSA has identified 5 priority areas to better meet the behavioral needs of individuals, communities, and service providers. Those 5 priority areas are: 1, preventing substance use and overdose. 2, enhancing access to suicide prevention and mental health services. 3, promoting resilience and emotional health for children, youth, and families. 4, integrating behavioral health and physical health care. And 5, strengthening the behavioral health workforce. And really, under the priority area 4, integrating behavioral health and physical health care, is the direction that is leading SAMHSA in the effort of eliminating hepatitis C. SAMHSA's work is guided by 4 core principles that are being integrated throughout the agency's activities. Those core principles are equity, trauma-informed approaches, recovery, and commitment to data and evidence. I do want to briefly discuss SAMHSA's working definition of recovery, which defines recovery as a process of change through which individuals improve their health and wellness, live self-directed lives, and strive to reach their full potential. SAMHSA has several grant programs that support hepatitis C work, and I'm going to go through them all briefly. I do recognize that we are running short on time, but I want to first highlight one of our barriers, which is that SAMHSA grant funds currently cannot be used to purchase hepatitis C medication, though certainly hepatitis C programs are integrated within some of the work that SAMHSA does through other funding sources. So first, I wanted to briefly mention our block grant, the Substance Use Prevention, Treatment, and Recovery Support Block Grant. This block grant, beginning in long ago in the 90s, states that had a case rate of 10 or more cases of AIDS per 100,000 individuals or HIV designated states. They are obligated to spend their 5% of their block grant funding on HIV early intervention services. Currently, only 2 jurisdictions qualify for this set aside, DC and Georgia. And I bring that up because there is second, within the block grant funding, support for viral hepatitis services. One of those supports is limited to HIV designated states with the mandated set aside. Therefore, viral hepatitis services for clients in substance use disorder treatment in the HIV designated states can qualify for enhanced viral hepatitis support. However, because of this antiquated definition, only 2 states currently qualify. The second and only other time when the substance use block grant can be used for viral hepatitis services is under this provision supporting women's substance use disorder treatment that's funded under the block grant, which allows the substance use block grant grantee to provide primary care for women in certain circumstances on individuals who have no other financial means to obtain such services. These are the 2 instances in which block grant funding can be used for hepatitis services. However, SAMHSA does have a variety of other grant programs that do not go to the states, but rather go to grant recipients that support viral hepatitis work. The first are 3 grant programs that are funded through the Minority AIDS Initiative. One is funded through each of our 3 centers. The Center for Substance Abuse Prevention funds the Prevention Navigator Grant Program that funds HIV and substance use disorder prevention services. The Center for Substance Abuse Treatment High-Risk Populations Grant Program provides substance use disorder treatment to people who are vulnerable to or living with HIV, and viral hepatitis services are integrated throughout that grant program, including testing for hepatitis C and referral to treatment. And then the Center for Mental Health Services supports the Service Integration Grant Program that integrates mental health services into HIV primary care settings. We also have our Harm Reduction Grant Program that started, I believe, in 2021 to 25 grant recipients that supports syringe service programs. And then we have, so those are our 3 or 4 main ones. However, we have 15 other grant programs that incorporate viral hepatitis services in some way, serving a variety of populations. The way that viral hepatitis services are integrated into those grant programs depends on the population of focus. So it's very individualized to each individual grant program. From that, I did just want to also highlight that, the siloing that Christian mentioned is something that we are also very aware of. There are some SAMHSA grant recipient organizations that I'm aware of that have fully integrated hepatitis C services into their opioid treatment programs, their methadone clinics, et cetera. However, those are more the outliers rather than the rule. So this is something that as we start implementing our strategic plan, which includes the integration of physical healthcare into behavioral healthcare, that's something that I hope that we will continue to see more from SAMHSA. So I think that's everything. Over to you.
Great, thank you all. You've covered a lot of activity underway now, including elimination strategies that each of these major public health programs has in place related to hepatitis C. We're going to just to follow up on this. We have limited time, and you all please keep the comments and questions coming using the QR code. I'll try to integrate them. But Christian, I want to go back to you for what do you want to see moving forward? What's most important for success of this kind of national initiative in conjunction with, as you said, all of the programs, Medicaid, potentially Medicare, HRSA, SAMHSA, et cetera, that influence and support how you practice and what kinds of practices you can sustain. Just to paraphrase a little bit, it sounds like you think some performance metrics related to hepatitis C would be helpful here, and I assume that'd be easier if they were kind of more unified across, HRSA, Medicaid, Medicare. Are there other steps, upfront funding, additional payments for people who are uninsured? What else is critical for you?
Yeah, thanks, Mark. First of all, I don't want to leave behind the availability of the drugs and then also the diagnostic testing. Those are key elements that I think it's great to see in the plan front and center. In California, honestly, our Medicaid prior authorizations have gone away, and so the drugs really aren't the issue anymore. It's more getting to that last mile to the patients where they are, and it's not the easiest thing to get outside of the clinic and go out on a nighttime and park your mobile van in front of a syringe exchange, and yet that's probably what needs to be done going forward. So that kind of activity, that sort of extra mile, happens only with a little bit of nudging, a little incentivization from those performance metrics, as you mentioned, but then also pilot grant projects. And then it's kind of an intangible, but just getting everybody on the same page. We've been trying to work on elimination efforts in different jurisdictions. San Francisco has a great elimination initiatives, as does Los Angeles and San Diego. But it really takes this kind of everybody on the same page, this federal effort, this awareness campaign, and then additionally training. We've had great success training primary care providers in treating hepatitis C, and I'd just love to see that on a little bit of a larger scale. And I think that can happen along with the incentives. If you had every one of the 14,000 FQHCs across the country incentivized to test and treat, I think they'd be doing a whole lot more of it. And then finally, I did make this comment earlier. I feel like the opioid treatment centers and the federally qualified health centers are really partners that are ready to work together. And right now, there's just these sort of artificial barriers between us. We could very easily go and partner and do testing and treatment on site at a methadone clinic, or they could be doing the testing and sending them over to us. There's a real opportunity there.
Yeah, and Kristen touched on some of those issues and priority at SAMHSA to address what you call the outdated siloing too. And just one follow-up maybe to take to the rest of the, maybe I'll go to Nate, to you next. You talked about some of the things that CDC can do to make this happen, including, among other things, the education, the availability for training and support, and then some funding too to help get these programs going. We're talking about a 5-year initiative. That's not necessarily permanent funding. Christian talked about seed funding, startup funding, if I was understanding correctly, that could help build these capabilities into care delivery. Is that part of how CDC sees this working?
Exactly. Yeah. So when we're talking about, alluded to it a little bit when I mentioned our envision for a training and technical assistant network, and now there exists some similar analogies of other networks out there, like AIDS education training programs or the addiction technology transfer centers, and we could very easily see something specifically tailored for hepatitis C. And you're right, we need to figure out a way for it to be able to support the development of programs for hepatitis C elimination in the settings that we care about the most. So as mentioned, the community health centers, the prisons and jails, OTPs, MAT clinics, and SSPs. And it's one thing to provide an option for provider training, and in fact, just the ECHO model has been so successful. I don't know that we necessarily need one other ECHO. I think the more availability of that is great, and if there's any gaps, we certainly want to fill them. But I think it's the real nitty-gritty challenges of how do you actually, I think as was mentioned a lot in the prior panel, of how do you get the reimbursement to work? How do we figure out how we can get the exact qualifications for the providers? How do we need phlebotomy? What other kind of workarounds can we do to make our ability to provide testing and treatment on site feasible? And that sort of stuff requires a fair bit of customization that perhaps we at the federal level can have a good sense of, but that's going to require working a lot with our local community partners, state health departments, in order to really get at that customized approach to make it work in each of these different settings, because they're so individually unique.
And you're right, that did come up a lot on the last panel. We heard about the collaborations in Washington State between public health and the Medicaid program in implementing plan amendments, other steps to connect patients who are in emergency rooms with Hep C testing, to connect them to medication-assisted therapy that could also address these steps. Lee, I know your part of CMS didn't cover Medicaid, but picking up on the last panel, it seemed like some funding directed to providing incentives for states to adopt these kinds of models in Medicaid might be helpful. One of the comments that we got was, gosh, this seems like all good ideas, but it seems like it's going to take years for it to happen. One way to accelerate that would be things like Medicaid spas with financial incentives attached. And one way that CMS attaches financial incentives, as Christian said, is performance measures. And CMS can also take steps to make it, to Nate's point, less costly and disruptive for healthcare providers who are really busy and stretched right now, especially in the safety net, to adopt new care models and change practices. What do you think about CMS roles here?
Yeah, I mean, it's a great point, and here is a major problem that's treatable, and through the Hep C treatment as far as the hepatomas and the hepatocellular cancer. So one of the key things is, right now it's a voluntary program for quality measures. And now that I'm outside, I can say, should this be in all the programs? There's alignment of quality measures across all of CMS. Should this be in the MA plans and the Medicaid plans and being it mandatory? I mean, how powerful, I think that gets to your comment, that would be to have sort of the same measure for all primary care providers throughout the country, and that's really an administrative priority. And I think besides the 1115 waivers, CMMI is trying to get into that space too. So I think there are multiple ways that you could have partnerships for paying for this at the state level.
I would say, though, that having been through a number of efforts to update performance measures, and by the way, along with that, to try to make reporting less burdensome, not to have to fill out another form that goes into a old-fashioned claim, but make it kind of more automatic, as you were talking about earlier in the coming from the electronic records. That takes consultation with, as we've talked about, the diverse healthcare providers around the country, the health plans that would be responsible for implementing. That takes a bit of time, and it takes a bit of administrative effort. So you talked earlier about the limited resources in the coverage and analysis group around what gets covered, like the point of care testing example. Is the same thing an issue here? Is this an area where some additional limited resources and support for alignment could help?
Well, all I know is that the original steward of the testing was the American one of the GI Society.
AGA.
AGA.
It's AGA. So the question really would be resources to say that it could be scaled into a Medicaid program. It could be scaled into HEDIS or into the plan. So I think that's less about creating the measure, but it could be about funding to ensure the measure actually can be utilized in multiple programs, the testing, the validity.
Yeah, I'll weigh in. We've been also thinking about this as well. I know my colleague Jessica Deeren from OIDP is in the crowd as well about, how do we come up with a way that we can find ways to get something for hepatitis C through the very bureaucratic, difficult layers of approval to have something rolled out on a national level. I think, who was it before that just mentioned, I just texted the Minister of Health and they imputed something and now, we're screening for all, baby boomer cohorts. That would be very, that could never fly here, obviously. And so I think we ask, because we're looking at a really shorter time frame, like you mentioned, this is a time-limited 5-year plan. What are we close to rolling out and what can get us there? And like you mentioned, we have these 2 AGA measures, and Michelle Schreiber did come to CDC and give a great talk about the concept of universality across these dozens of CMS quality programs. And I think there's certainly potential to think about how we could use these measures and take them to the next level with some additional support to those kind of next generation, FHIR-based, very automatic electronic clinical quality measures that can be low burden to the providers and get us the data that we need to figure out what's quality.
And if I could just say, getting back to Allsite, there's a program called Re-Up that they recently published on Michelle and Doug Jacobs, that rewarding those providers who serve a more underserved population for doing high quality care. This is, as I'm thinking about it, this is the ideal program for that, given the population most at risk.
Is there Kristen, let me see if you've got anything to add. So a lot of interest, as you heard, in aligning some of the relevant SAMHSA program for behavioral physical health integration into these efforts, and that is part of your strategic plan.
Yes, certainly. So this is something that I expect we'll see more of from SAMHSA, this integration. As I said, we're still in the baby stages because our strategic plan was released in August. However, based on internal conversations that we've had within the agency and based on the continuing need that we see writ large across our portfolio, this is something that I expect that we'll continue to see leaned into from SAMHSA. And other than that, we're aware, as I said, of the antiquated siloing between behavioral health care and physical health care, and that's why it's one of our 5 priority areas.
And I know we're about out of time, but I want to give you all are doing a better job of summarizing and identifying key issues in this area of cross-federal program coordination and turning short-term initiatives into long-term fundamental built-in change. So maybe I'll go to Christian first and then Lee. What is it going to take at the state and local level in terms of these different organizations working together, maybe in a way that's nudged or encouraged by a national initiative, in order to get this better, faster alignment that you all have been talking about?
Well, just during the last comments, I was thinking about some of the real out-of-the-box and non-traditional ways that we need to get out there to diagnose and treat people. And one of those is street medicine, for example, backpack medicine. We're starting a new initiative literally at the tent camps in San Diego and being able to test and treat people there. Testing at methadone clinics and opioid treatment centers, doing things that are a little bit less traditional, but just allowing people to get reimbursed for them. That's really the key. We kind of know what to do at the ground level. We see patients all the time. Part of the problem is we can't diagnose and treat them in the same visit. We can give samples for a newly diagnosed HIV patient to get them started on that day, but we can't do that for hepatitis C yet. And we can do a rapid diagnostic test and know if somebody's HIV positive and get things rolling. But those are other problems to solve. But just allowing us to be properly reimbursed for the work that needs to happen, I think that's a very simple concept. It takes a lot of legal and regulatory work to get there, but that's the main principle, I would say.
And see, Lee, maybe to close this out from the CMS standpoint. So CMS has some mechanisms in place through CMCS and their SPAs. They have pathways for better, more aligned reimbursement, which I think could extend to drug coverage as well, Part D plans, as well as primary care providers. Is this a resource issue? What could accelerate it? What should Congress do?
Yeah, well, Congress, besides giving the money to get these point-of-care tests covered and changing the national coverage decision, CMS during the pandemic actually developed a code to go in and pay more going home by home and giving the COVID vaccine. So back to Christian's comments about resources. I think CMS, if Congress gave the authority, could develop more codes to really go into that community.
And CMS has actually this past year expanded some of its care coordination, chronic care management codes to a broader range of providers in primary care settings. Maybe it's not as clearly aligned with some of the Medicaid reforms and some of the steps needed, particularly for hepatitis C, but it does seem like there's a foundation there.
Absolutely. I know it's a priority of the administrator, so I hope they can see a path forward.
All right. Well, I want to thank you all for a great discussion to round out today. So as you all can tell, we've had a lot of ground to cover today, and so I am not going to try to spend time summarizing it in my minute and a half left, except to say that we really appreciate all of you being here and contributing to ideas building on the national plan announced by the Biden administration, building on many of the ideas that people in this room and with us online contributed to in this kind of comprehensive look across the many things or many programs that are available to help support hepatitis C elimination, and hopefully coming out of these discussions some clear ideas about the nudges, the specific coordination steps that are needed. As Christian mentioned, getting to simplicity, getting to alignment, and getting to ability to support and tailor the right incentives and the right long-term financial supports to each local community in these innovative treatment settings that are critical here seems like a valuable path forward, and hopefully through collaborative efforts like this, we can get there faster. So I want to thank all of our panelists who shared their perspectives on state, local, and federal levers and actions that can support a national elimination plan. Thanks again to Arnold Ventures for funding and support to make this workshop and the associated activities and research possible. And thanks especially to people who I know had a very busy weekend last weekend and not having necessarily going out and just having fun. Bina Buyan Khan, Christina Bush, Tori Gem, Hannah Gronke, Luke DeRocher, and Hannah Vitiello. It took a group to put this together at Margolis and beyond, and we are going to see, as you all have seen, Duke-Margolis really places a high priority on public health, healthcare coordination to address these population health programs. I'm coming out of this meeting thinking that the opportunities are just better than ever, so we look forward to continuing to collaborate and work with all of you to turn this tremendous potential into reality. Thank you all very much for being with us today.